Thank you for joining us for the National Health Service Corps' 2012 webinar series. Tonight's webinar is Preventing Childhood Obesity, Motivating Wellness and Physical Activity in Childhood Development, presented by Dr. Bernard Abbott. Dr. Abbott is a pediatrician and the Chief Medical Officer at the South Baltimore Family Health Center. He is currently an attending physician at both Harbor Hospital Center and Mercy Hospital in Baltimore. He also has been a preceptor for nurse practitioners and nursing students at Johns Hopkins School of Nursing, as well as a clinical preceptor for medical students at the University of Maryland College of Medicine. Tonight's webinar goals are to discuss obesity statistics in adults and children, what children think about obesity, metabolic complications of obesity, how to decrease obesity in children, and to discuss diets and are they helpful. NHSC is pleased to offer continuing education units and continuing medical education credits of 1.5 hours for all disciplines participating in this webinar. To receive these hours, you must attend the full 1.5-hour session. Throughout the webinar, you will be required to respond to online poll questions to verify your attendance. Once you respond to all the polls, your attendance will be noted for the accreditation process. At the conclusion of the presentation, the operator will provide instructions on how to submit a question through the conference bridge line. There will also be an evaluation after the question and answer session. We would greatly appreciate it if you took a few minutes to fill it out so we can continue to improve our future sessions. Thank you again for joining the 2012 NHSC webinar series. We hope you find this webinar useful to your daily efforts to provide service in your community. Now please welcome Dr. Bernard Abbott.
Good evening, everyone, and thank you again for joining us today for this topic on childhood obesity. As Barbara said, I'm Dr. Bernard Abbott, and I just want to start off by saying if you had asked me 10 or 15 years ago to give a talk on childhood obesity, I probably would have said, no, I really can't do it for a number of reasons. Probably number one is because I just didn't have the knowledge base in order to present a lecture on childhood obesity. Since then, I've been able to learn quite a bit about childhood obesity, and also because I've been seeing so many more patients over the last 10 years who present with being overweight and being obese, it's really forced me to take a very, very serious look at childhood obesity and see if there's something I can do as a pediatrician and to help them overcome this terrible disorder, okay? Now, as Barbara said, we're going to talk about some obesity statistics in adults and children because obviously we have more information about adults, and you need to know about adults before you can really appreciate how difficult the problem is in children. And we want to talk about what kids think about obesity. Oftentimes, over the years, we have no idea what our children actually think about their bodies and how they try to deal with some of the issues that they have. We also want to talk about the metabolic complications, and we'll go into some of the things that I've experienced in my practice. And I'm not going to give you a panacea on how to stop obesity in children because if I had that, life would be very, very easy. Unfortunately, it's a very difficult problem, and it requires a multidisciplinary approach. We want to talk about diets. I don't like using that word diet. And we want to talk about are they helpful. Before I begin, let's talk about a case presentation that is typical of what I see in my office. Again, 10 years ago, I never really focused a lot on the kids who came to my office who were obese, but now I have to. Now, KD is a 17-year-old female, and she comes into the office for a routine physical exam. KD is the young lady in the blue. Her mom is in the middle, and this is KD's younger daughter. Now, KD's weight was found to be 243 pounds. Both the mother, father, and sister are all overweight. Now, KD's blood pressure was within normal limits, and I want to emphasize, always get a blood pressure in your adolescents when they come in. But her BMI, her body mass index, was greater than 30. Now, KD appears depressed, which is not unusual in adolescents. The majority of my adolescents who come to me for routine exams have a look that suggests that they're depressed. And I've learned over the past couple of years not to ask, are you depressed, but to ask simply, how are you dealing with your depression? And you'd be amazed at how many times you get the answer, how'd you know I was depressed? And I say, well, it just seems like you looked a little depressed. And it opens up a Pandora box of questions at that point. So don't be surprised if you get a positive response about depression from your adolescents. Now, what do you think the first thing Mom said to me when they came into the office after I said hello? Mom said, Dr. Abbott, you got to do something about my daughter. She's overweight and she's too fat and we need to do something about it. Well, at that point, of course, the wall that Katie brought up was almost impossible to get over. She went into shutdown and I could not reach her at that point. Her sister, who was younger, went into the corner and tried to become invisible, hoping that Mom would not say anything negative about her. The question is, why would Mom say something so negative about their daughter, or her daughter, who she obviously loves, but yet did not have the sensitivity to not say something that's so devastating? Well, I think Mom was extrapolating her feelings of being overweight and her feelings about being unable to keep her life in order and extrapolating that on her daughter. And that is often typical. And you see this in a lot of families when you're trying to work with patients who are overweight or obese. Now, before we go on, let's make sure that we're on the same wavelength regarding overweight versus obese. An overweight person, overweight means weight greater than a set standard. It may be muscle, bone, or fat. An obese person has a high proportion of body fat. An overweight person has a BMI of greater than the 85th percentile, and an obese person has a BMI greater than the 95th percentile. And we'll talk more about BMI in a minute. Now, what is BMI? Well, BMI is a better measurement of obesity than weight for height. And how do we calculate it? Well, it's the weight in kilograms divided by the height squared in meters. Now, we use it in children age 6 and older. Under age 6, it's kind of hard to get standards for BMI because the child is constantly changing as they grow during the first, say, 12 to 14 years. But they are looking at, the CDC is looking in to see if they can come up with some standards for children under the age of 6 regarding their BMI. Now, this is a graph that shows the BMI changes throughout childhood. And I think it's important to look at that to understand how it changes. Now, the average baby who's born in the United States is about 7 pounds, 6 ounces, give or take an ounce or two. During the first year of life, their BMI averages around 16 to 17, okay? Now, during the first 3-4 years of life, the baby's BMI, or child's BMI, decreases considerably. And there are a number of factors for this. Number one, the terrible twos. Toddlers run everywhere, okay? And they don't eat like we want them to eat. Oftentimes, parents come to my office and they complain that their baby, their 2-year-old or 3-year-old, will not eat. And I explain to Mom, well, toddlers have a tendency not to eat breakfast, lunch, and dinner at the table like we'd like them to. But I suggest what you should do, Mom, is to put food on a plate, let the child come, eat a piece of potato, run and play, then they'll come back when they're ready, eat a piece of chicken, go play, come back and forth. And that's how they eat oftentimes throughout the day. But what's the biggest problem that we have with children in the 2, 3, 4 age group is sweet drinks. Oftentimes the parents give the kids a lot of fruit juice, and that can be a problem. And I tell moms, if your child drank 4 ounces of orange juice and they didn't eat, you'd be upset. But if the child ate a half an orange, for example, you wouldn't be so upset. And I tell them it's the same principle. Their stomach fills up with the juice or the sweet drinks, and they're not going to eat breakfast, lunch, and dinner. And once I explain that to them, then they understand better. And I think it's important to educate parents about sweet drinks, and we'll talk a lot more about that as we go along. Now, around 4 to 6 years of age, the BMI is still going a little bit low. But around 7, 8, 9, 10, the BMI starts to increase. And that's normal because children have a tendency to pick up more muscles and they get taller and so forth and so on. And another thing that happens between, say, 6 and 10 is that children can now play sports. And they can play team sports because everybody gets to make the team. There can be 30 kids on the football team, 25 kids on the basketball team. They all get trophies. They can all play. But what happens after that, say around 12, 13, or 14, we notice that the BMI starts to increase. Part of that increase, of course, is because they're beginning puberty. But another problem is that kids at that age, unless they're athletes and are good athletes, they don't make the team necessarily. So if they don't make the team, what do? They play video games, they watch TV, and all of a sudden they are sitting at home on the couch eating snack foods and playing video games. And as you can see, after age 16, the BMI continues to rise. Now, this curve that we see now is moving upward because the babies are being born bigger, and the curve is now moving up, which means our kids are starting off bigger, and they're getting bigger as they get older. Now, this is a graph or chart or whatever that I sometimes Xerox for some of my patients who are very, very motivated and wanting to lose weight. And what it does, it allows them to calculate their own BMIs and also the BMIs of their family members. But you have to be careful because sometimes the kids will go home and they'll calculate grandma's BMI and tell her, Grandma, you're obese, and that can create a problem. So you have to make sure you give these to kids and families who are motivated. But as you can see, a child who has a BMI or a person who has a BMI of 18.5 is considered underweight. Normal value for BMI is between 18.5 and 24.9. Overweight is between 25 and 29.9, and obese is considered a BMI greater than 30. Okay? But this gives you a rough guideline on how you can look at BMI. I don't use BMI as my number one criteria to determine if somebody is overweight or obese. I use it as a guideline because, for example, if you have an older child, an adolescent, who is very muscular, has excessive height, their BMI may be high, but they may not necessarily be overweight. So use it as a guideline. Now, what about adults? Let's talk a little bit about some obesity statistics of adults. And as you can see here, this is two of our nurses, our pediatric nurses. The one on the right, she used to be our pediatric nurse, and the one on the left is our current pediatric nurse. And I know it appears that I have only hired nurses who are overweight, but that's not the case. Both are still trying to lose weight very, very seriously, but it's very difficult for them. And even though they like for me to bring cakes and cookies in for them, I had to stop doing that because I didn't want to be an enabler. And the current nurse, Phyllis, she gets very upset sometimes if I don't bring in her red velvet cake, but I told her, no, if you're trying to lose weight, I want to help you do that, and now she appreciates that. So, what about statistics in adults? Well, less than half the American population is at a healthy weight. Currently, about 64% of adults are within some definition of obesity, from overweight to morbid obesity. It's approximately 129 million adults. Women and men are about equally represented, about 64 million women and 65 million men. $58 million people in the United States are overweight, 40 million are obese, and 3 million are morbidly obese. 78% of Americans don't meet basic activity level recommendations, and 1 out of 4 Americans are completely sedentary. Now, what does that mean? They get up, eat breakfast, go to work, eat lunch, come home, eat dinner, watch TV, go to bed. They have no physical activity at all. And what's alarming is that there's been a 76% increase in type 2 diabetes in adults 30 to 40 years old since 1990. Now, if you'd asked me 10 or 15 years ago how many kids I had with type 2 diabetes, I'd probably say very, very few, maybe 1, 2, or 3. Now, I have so many kids with type 2 diabetes that I can't keep track of them. Now, how bad has obesity gotten in the past 20 years? Well, let's look at obesity trends since 1985. Now, some of you may have seen these maps in the past. These are done by the CDC, and they look at obesity trends among U.S. adults. And it starts back in 1985. And let me explain to you what these maps look like if you haven't seen them before. The white states are states that had no data collected. The light blue are states that had an obesity prevalence less than 10%, and the darker blue are states that had obesity prevalences between 10 and 14%. Now, what do we mean by obesity trend? What they did, they looked at people in these states who had a BMI greater than or equal to 30 or were 30 pounds overweight for an average size of about 5 feet 4 inches tall. Okay? And they just basically did a statistical study to see how many people fell into this category. In 1985, we had no states had an obesity prevalence greater than 10 to 14%. But let's move on. Look at 1986, we're still doing pretty well. Still half the country doesn't have any statistics at all. 1987, we start to see that more states now have obesity prevalences between 10 and 14%. By 1988, again, about 1/3 of the country now has an obesity prevalence between 10 and 14%. By 1989, almost half the country. And 5 years after they started looking at this study, they see now that definitely more than half the country now has an obesity prevalence between 10 and 14%. Again, BMI greater than or equal to 30 or 30 pounds overweight. Still, we're not in bad shape in 1990. Let's look at 1991. Now we start to see 5 states or 4 states that have an obesity prevalence between 15 and 19%. Okay. Again, look at 1992. By 1993, pretty much the entire country, except for one state, Colorado, who didn't have any data at that point, had an obesity prevalence either between 10 to 14% or 15 to 19%. 1994, now even Colorado is in the picture. They finally started giving us data. But still, we're not too bad. We're still below 19% obesity prevalence in the country. By 1995, 10 years after we started looking at obesity trends, we now see that half the country now has an obesity trend between 15 and 19%. We're getting bigger and bigger and bigger. Let's move on. 1996, 1997. So 12 years after we started looking at obesity trends, we now have 3 states, Mississippi, looks like Kentucky, and Indiana now has an obesity trend greater than 20%, which again means that of the people they looked at in those 3 states, either 20% or greater of those people that they looked at were either had a BMI greater than 30 or were 30 pounds overweight. Look at 1998, more states now. By 1999, more than half the country now has an obesity trend greater than 20%. By 2000, which is 85, 90, so by 15 years after we looked at this, now more than half the country has an obesity trend greater than or equal to 20%. We're getting bigger and bigger as time goes. Now, by 2001, we have one state now, the great state of Mississippi, now has an obesity trend greater than 25%. Okay. The next year, 2 more states came, Alabama and West Virginia. Again, in 2003, Indiana now has an obesity rate greater than 25%. And by 2004, about 1/4 of the country now, particularly in the southern states, now has an obesity prevalence greater than 25%. By 2005, 20 years after we started looking at this, we now have 3 states, Louisiana, Mississippi, and West Virginia, who now have obesity rates greater than 30%. Again, our country is getting bigger and bigger. But I do want you to notice that Colorado, still doing pretty well, and some states up here, which are New Hampshire, Vermont, Massachusetts, all doing pretty well, have obesity rates between 10 and 15%. 2006, 2007. By 2007, we now have 3 states that have obesity rates greater than 30%. And Colorado is still doing very well, but you notice that the New England states increasing in obesity. Let's look at 2008. By 2008 now, we have 6 states that had obesity rates greater than 30%. Okay? So as you can see, other than Colorado, we've been doing pretty poorly in terms of how we've been handling our obesity. Now let's look at 2010. Okay? Well, in 2008, we had 6 states. Now we have 12 states now that have an obesity rate greater than 30%. So it's not getting better, it's getting worse. Now, I'm not sure where each of you work, but where I work in inner city Baltimore, the majority of the patients that I see are on medical assistance and they're African American. However, we are recently, over the last 5 years, had an increasing number of Latino patients and Hispanic patients who have moved into the area, and we're been forced to make sure that we understand some of the ethnic differences between African Americans and whites and Latinos. So I put this slide up to show, well, briefly before I do that, I just wanted to show you in graphic form the changes of the country from 1990 to 1999 to 2008. Okay. Now this is a map showing the obesity prevalence between 2006 and 2008, just looking at Hispanics. And you can see one state, which is Tennessee, had an obesity prevalence greater than 35, okay? But overall, the obesity prevalence was greater than 25% in most of the states. Now compare this to black non-Hispanic, same time period, 2006 to 2008. Notice the tremendous difference in the number of states that have obesity prevalence is greater than 35, okay? And finally, compare this to white non-Hispanics, you can see a tremendous difference between Hispanic patients and African American patients regarding obesity prevalence during that time period. So in conclusion, during the past 20 years, there's been a dramatic increase in obesity in the United States. In 2008, only one state, Colorado, had a prevalence of obesity less than 20%, and now that is gone. They're greater than 20%. 32 states had a prevalence equal to or greater than 25%, and 6 states, Alabama, Mississippi, Oklahoma, South Carolina, Tennessee, and West Virginia, had a prevalence of obesity equal to or greater than 30%. And as a slide I showed you before, in 2010, 12 states now have obesity prevalences greater than 30%. Now, what do we do about our kids? All right, we talked about adults, but as a pediatrician, my main focus is on how we can prevent our children from becoming involved in that obesity epidemic. Well, first of all, it's very difficult to accurately assess overweight statistics in children as data is constantly being collected. The CDC has been collecting data over the past 10 years, but we still don't have a good idea of just how bad the problem is. But we do have some idea how things have changed. Now, this is a graph that shows the prevalence of overweight children and adolescents ages 6 to 19. And this starts from 1963, early 60s, all the way up to 2002. And you can see in the late 60s, early 70s, we had an obesity prevalence of kids 6 to 11 and 12 to 19 of about 4%. By 2002, it had quadrupled to 16%. Okay. Another slide showing the same thing. In the early 60s, late 70s, obesity prevalence between 4 and 5% for 6 to 11-year-olds, and the yellow was 12 to 19-year-olds. And again, by 2000, it had increased fourfold. Another graph showing kids 2 to 5 years of age in the early 70s. The purple here is age 6 to 11, and the white is age 12 to 19. Again, a fourfold increase in obesity trends between 1971 to 2004. And the last graph I want to show you, again, shows early 60s all the way up to 2004. The light blue, children 6 to 11 years, and the red, adolescents 12 to 19 years. Tremendous increase starting in the mid-70s. We were doing okay up until about the mid-70s. The question you have to ask yourself is, what happened during the mid-70s that caused such a tremendous increase in our children being overweight and obese? And we're going to talk more about that, but I want you to keep in the back of your mind the mid-70s, early 80s, and what happened during that time period. So to summarize, obesity trends in children over the last 40 years, the prevalence of obesity has increased from 5 to 12% for 2 to 5-year-old children. It has increased from 6 to 17% for kids 6 to 11 years old. And for kids 12 to 19 years old, the obesity prevalence has increased from 5% to 17%. And this picture kind of gives you a good idea of why we think this increase has occurred. And we'll talk more about this in a minute. Now, he's overweight. Why? Well, diet, fast food, obviously, is a major factor. If you supersize it, you increase the calorie count 3 times. For example, back in the early days of McDonald's, do you know what the normal adult meal was? It was a Happy Meal. That was what the adults got when they came into McDonald's when it first opened and wanted a hamburger. Now, you can get the super double, triple burger with the extra large fries and the supersized sweet tea or Coca-Cola, and you can imagine the calorie count has increased from 600 to 1,800 calories or more. Exercise. Our children just don't exercise like they used to. When I was a child, I spent 70% of my time outdoors, riding a bike, roller skating, doing whatever I could. Couldn't get me in the house if my life depended on it. Nowadays, especially where I work in the inner city, parents are afraid to let their children go out and exercise or even do any kind of fun activities. And I often ask my kids, what do you do for fun? And they say, I said, stay at home. I said, what do you do at home? Play video games, watch TV. I said, do you go out at all? Nope, don't go out. Why not? My mom won't let me. And believe me, I understand the concern. I've had too many children where I work in my neighborhood that have either been shot or seen somebody get shot or seen violence. So I understand why parents don't let their children out without being supervised. But exercise is something that we no longer do. Genetics. Rarely is it a genetic problem. There are a few genetic disorders that can cause obesity, but in general, that's not what's causing our obesity epidemic at this point. Endocrine problems, a lot of times grandparents will tell you that they have gland problems that run in the family. Often not the case. However, if the grandparents or the caregivers or the parents are really concerned, there's nothing wrong with doing a T4 and a TSH just to make sure there's no problem with the thyroid. But I can honestly say I don't have any patients where their obesity or being overweight is caused by an endocrine problem, and if I do, it's very rare. Cultural behavioral factors, again, we talk about cultural factors. If the family eats a certain way, high fat content diets, they don't exercise, then generally the children are going to follow that same pattern, and that's what generally cultural and behavioral factors mean. Found environmental effects on a susceptible population, basically that means kids who live in the inner city simply do not have access to the same things that children in more affluent neighborhoods have. For example, vegetables, fruits, and so forth and so on. There's a supermarket across from my office, and I went in there one day just to see what they had in there, and the fruit and vegetable section was so small, and there were so few fruits in the fruit section, and the prices were so high. And I asked the store owner, I said, why do you have such minimal amount of fruits and vegetables? And they said basically because nobody buys it, and the fruit goes bad, we end up having to throw it away. But you go to the frozen food section and the snack section, loaded, okay? And that's where you see most of the parents shopping for their kids. So that's a big problem. Now, some people say we even have an epidemic of 6-month-olds. Now, I do say that I'm seeing a lot of my infants now who are much bigger than they used to be 5 or 6 years ago. But is it an epidemic? It could be. Now, why do some people say that? Well, the question is WIC adding to the overweight problem in babies? Now, I want to emphasize that I think WIC is probably one of the most important programs that our children have, especially in the inner city. And to not have WIC would be a detrimental thing for a lot of our parents and children. However, the problem with WIC sometimes can be what they give the mother. How many times have I had a mother who brought me a WIC form saying they needed more formula? And I asked them why. Because the baby drank all the formula that I have and I need more. And we sit down and we talk to the mother about, well, how much formula are you giving the baby? Keep in mind there are two things that are the most important to a mother or family when they have a newborn. First is, are they eating well? If a child is eating well, the parents feel like they're doing a good job. The second thing is, are they pooping properly? If the baby is passing good stool, mom's happy, but if the baby is constipated, it creates a tremendous amount of anxiety. If the baby is not eating right, it also creates anxiety. So generally what I do with my mothers when they come in, I say, listen, how much are you putting in the bottle? And they'll tell me 8 ounces. I say, well, how often do you feed the baby? Every 4 hours. I say, Mom, your baby can handle about 3 to 4 ounces every 4 hours. The baby is getting too much formula. Once they realize that, then they say, oh, I didn't know. So the point is you have to educate mom about what is important and how to feed the baby. Now, if you look at the WIC, at the Similac here, you notice that it has 43% corn syrup solids. It also has 10% sugar. 1 12-ounce can of Coke has about 10% sugar in it, okay? So the problem is not the formula, it's that our mothers are giving too much of it too often. The other problem is WIC provides juices, and mothers always give too much juice, it seems. When they come to the office for their visits, they always have their sippy cup. Mom, what's in the cup? Juice, okay? And if the child is drinking juice all day long, they're not going to eat food. So you have to keep that in mind and educate parents about nutrition and how to feed their kids. Now, what about statistics in children? Well, according to the year 2000 statistics, about 15% of children 6 to 11 and 15% of kids 12 to 19-year-olds were overweight. 4% of kids were overweight in 1982, but 16% in 94. 25% of all white children were overweight in 2001, but 33% of African American and Hispanic children were overweight in 2001. More than 9 million children and adolescents were overweight in 2000. Approximately 17%, or 12.5 million of our kids and adolescents aged 2 to 19 years are obese in 2011, and 1 out of 7 low-income preschool-aged children is obese. Something we can do to prevent this. Now, what about hospital costs? Hospital costs associated with childhood obesity have skyrocketed from $35 million in 1979 to $147 billion in 2009. Before long, obesity will surpass tobacco use as the most preventable, and again I want to emphasize, the most preventable health epidemic of the 21st century. Now, how much does obesity cost us overall? Well, if you look at health-related costs of obesity compared to just being overweight in the United States, the average American man will pay almost $2,600 a year more for healthcare costs by being obese. The American woman will pay almost $5,000 more per year, and American men have a 6 times higher healthcare cost, and American women 9 times higher healthcare costs by being obese compared to just being overweight. And by 2030, it's estimated that healthcare costs due to being overweight and obese could account for 16 to 18% of total healthcare costs. If we could decrease that by 1/4, we could pay for the entire healthcare program. Now, what do our kids think about their bodies? Now, it's difficult to determine statistics in children because there's no definite established criteria, but the YRBSS, which is the Youth Risk Behavioral Surveillance System, was conducted by the CDC in 1999, and basically what it did, it taught the kids in grades 9 to 12 and asked them, what do you feel about your body? How do you handle feeling that you're overweight, and what do you do? And I just want to go over some of the things that the kids told us because we had no idea this is what they were thinking about. 16% of high school students were overweight. That is, they had a BMI greater than 95th percentile. 10%, 1 out of 10, were obese, BMI greater than 95th percentile. Males were more overweight and obese than females, and black students were more overweight than white students. More black and Hispanic female students were overweight than white females. 30% of kids described themselves as overweight. So 1 out of 3 children thought that they were overweight to some degree. More Hispanic students felt they were overweight. Again, I emphasize you have to be aware of the different ethnic ideas in Hispanics, African Americans, blacks, Caucasians, because they think differently about their bodies and how they approach eating and foods. 43% were trying to lose weight, so almost half the kids in the study were trying to lose weight, and twice as many females and male students were trying to lose weight. Surprisingly, more Hispanic students were trying to lose weight compared to white and black students. Why is this important? Because now when I have Hispanic families in my office, I have to ask more questions about food, diet, so forth and so on. What about exercise? Almost 60% reported they were using exercise to lose weight. More females than males use exercise, and more white female students use exercise compared to black female students, but not by a big margin. What about change of eating habits? 40% of the students reported they ate less food and had fewer calories during 30 days before the survey. Twice as many female students ate less than male students, and more white students ate less calories than black students. More white female students ate less than Hispanic and black female students. So these are things you need to be aware of. Now what about change of eating habits again? 13% of students reported fasting without eating for 24 hours or more before the study. And more female students, 19%, reported fasting compared to male students. Now, why is that significant? You got to remember, high school, or grades 9 through 12, is very stressful on its own. They have 6, 7 classes. They have to concentrate all day. It's not easy. And if the child doesn't eat properly, they're not going to get enough glucose to their brain, so they're not going to be able to concentrate to learn. So by 4th, 5th period, they are just wiped out because they just don't have the calories in order for them to study. So it's important to know that almost 1 out of 10 kids were trying to fast before the study was done. Now what about diet supplements? 8% of students reported taking diet pills, powders, or liquids without a doctor's advice. More female students reported taking diet pills than males, and 5% of students reported vomiting or laxative use to lose weight. If you find a child is vomiting and using laxatives, that's a sign that they may be developing anorexia nervosa or bulimia. They need to be referred right away to a mental health provider. Now this is a child who was drinking a Red Bull because 5 years ago, Red Bulls were popular. Why? Because girls thought that if you drank 3 or 4 Red Bulls during the day, you would lose weight because you'd lose your appetite. Fortunately, that has gone out of way now, and they're not doing that now, but who knows what they're doing right now. So who is at greatest risk? Well, you can see African American girls, Mexican American boys, inner city boys and girls, and any child with a family history of obesity. And you also need to add Native Americans because they have an increasing number of problems with being obese and overweight as well. Now why do we worry about it? Now this is just a small list of the obesity-related comorbidities, and I'm going to go through them relatively quickly, and we'll talk about a couple of them in more detail. Type 2 diabetes, we know. Coronary heart disease, high LDL bad cholesterol, stroke, hypertension, non-alcoholic fatty liver disease, gallbladder disease, which I did not realize 10 years ago. In fact, more and more children now are coming to the doctor with non-alcoholic fatty liver disease, and it's a big problem now in adolescents who are overweight. So think about liver disease in children who are overweight. Degenerative problems of the cartilage and joints, a big problem. Sleep apnea and other lung problems like asthma. Some forms of cancer, rectal, colorectal, endometrial, kidney, breast, all have a higher risk in patients who are obese, especially colorectal. Complications of pregnancy we know about, menstrual irregularities in girls who are overweight, their menstrual cycles are often very late. And I put this in red, depression and anxiety and discrimination in life. Most of the kids who are overweight, whether they admit it or not, are depressed and have anxiety. And many of them, if not all, have to deal with some form of discrimination either at school, at home, so forth and so on. So don't take those two things lightly. And remember earlier I said I don't ask patients if they are depressed. I ask them, how are you dealing with the depression? And again, you'd be amazed at how many times you'll get a positive response. So in summary, 70% of cardiovascular disease is related to obesity. 80% of type 2 diabetes is due to obesity. 43% of breast and colon cancer diagnosis is seen among obese individuals, and 30% of gallbladder surgery is related to obesity. Finally, 20% of obese people have related high blood pressure. All things we already know. Now let's talk about type 2 diabetes real quick. Now one study found that as many as 25% of obese children already show signs of early glucose intolerance, which is a precursor of type 2 diabetes. And this is really sad when you think about it. It's been estimated that a child with type 2 diabetes at age 10 will lose between 17 and 26 life years to the disease, something that we can prevent. What about the metabolic syndrome? What is that? Well, the main cause of insulin resistance in children is obesity. Insulin resistance is a driving force for many of the adverse cardiovascular risk factors, including dyslipidemia, hypertension, and diabetes, known as the metabolic syndrome. So what this slide really says is that if a child is obese, especially in the early years, they have a much greater risk of developing the metabolic syndrome as they get older. Now what about respiratory complications? Obstructive sleep apnea. About 20 years ago, I had a young girl who was about 5 years old, came to me with a cold. Mom said, can you give me something for her cold? I did the exam. She did have a little cold, nothing serious. She was not obese, okay? I said, Mom, if she's not feeling better in a couple of days, bring her back. She brought her back 4 days later, still had the cold, nasal congestion. I said, Mom, everything's still fine, just a cold, no ear infection, no pneumonia. Mom got frustrated, took the child to a pulmonologist. Came back to me about a week later, knocked on my door and handed me a piece of paper. She said, read this. The impression was, the worst case of sleep apnea we have seen in this clinic in a long time. But that was 20 years ago. I would never make that mistake again. Any child now who comes in with nasal congestion, whether they're obese or not, but particularly if they're obese, is I ask a very simple question. Mom, does your child snore? You'd be amazed how many times you get, yes, how'd you know? I said, I didn't know, but I asked that question now because I'm so concerned about missing obstructive sleep apnea. Any child who snores for more than 6 months to a year, has chronic congestion, even if they don't have enlarged tonsils, I strongly urge you to do a referral for a sleep study, okay? The insurance will pay for it as long as you document it properly. So what is obstructive sleep apnea? Well, obesity is definitely a risk factor. Children often awaken constantly at night. Why? Because they can't get that REM sleep, that REM sleep, where the rapid eye movement sleep. So they sleep, but they wake up. They don't even wake up all the way. And the next day in school, they're exhausted. They fall asleep on the desk at school. It can lead to poor school performance. So I ask, Mom, how's the child doing in school? And if they tell me she's having trouble staying awake, and usually they'll say she needs vitamins. Could be sleep apnea. In severe cases, and I've only had 2 that require CPAP, but CPAP is a terrible machine for a child to have to use every night. But I did have 2 kids who needed it, and they're doing well now. This, in summary, is a difficult diagnosis to make. You have to ask about it. They're not going to tell you my child snores. Even if you ask a sibling, they'll tell you the child snores. But as clinicians, whether it be dentists, mental health professionals, nurses, if you suspect it, just ask Mom, and if they say yes, refer that child to their doctor. Now, what is causing our obesity epidemic? Quiz. What do the Atkins diet and the Japanese diet have in common? Well, the Atkins diet is all fat, no carbohydrates. The Japanese diet is all carbohydrates, no fat. Do they work? Sure, both of them work. So that tells you it's not what we eat, or exactly, but it's how we eat and some of the things we do eat. So you can go and cut out all the fat, you can cut out all the carbohydrates. That does not necessarily mean that you're going to lose weight and keep it off. But they both eliminate fructose. So we're going to talk about fructose right now. Now, Atkins said that there is an important unrecognized factor in Western eating habits leading to obesity. Primarily, he believes that the main cause of obesity is eating refined carbohydrates, particularly sugar, flour, and high fructose corn syrup. Rice is the main carbohydrate food in Japan, consumed with just about every meal. However, the real basis of the Japanese diet is not rice, but fish, so they eat more protein. So, how has our caloric intake changed? Do we eat more? Yes, we do. Right now, teen boys are eating about 275 calories a day more now. Adult males about 187 calories per day more. Adult females are eating about 335 calories a day more. We are all eating more carbohydrates, especially more soft drinks, 42%, and fruit drinks, 35%. Now, does high fructose corn syrup really cause obesity? The controversy. A lot of experts on obesity feel that high fructose corn syrup is the main culprit in the obesity epidemic. I'm not going to go along with that, but I do think it does play a major factor in the number of kids who are overweight now, because high fructose corn syrup is found in everything just about that we eat. Now, this is just a slide that shows our consumption of high fructose corn syrup starting in around the early 60s all the way up to 2000. And this is the per capita consumption. And notice in the early 60s up to early 70s, we didn't use any high fructose corn syrup. But over the next, say, 20 years or so, our consumption of high fructose corn syrup increased tremendously. Now, what is high fructose corn syrup? Well, it's a carbohydrate. It's a natural sweetener made from corn. It's not handled by the body the same as sugar, though. And it has the same number of calories as sugar, but it is sweeter than sugar. And it's detrimental in high amounts. But also sugar is detrimental in high amounts. So the problem is not that high fructose corn syrup is so dangerous, it's the fact that we eat so much of it. Now, let's look at the relative sweetness of carbohydrates. If we use table sugar as our standard, 100, we see that high fructose corn syrup is 120. Fructose that's made in the lab has a sweetness value of 173, really sweet. But look at lactose, which is the sugar found in milk, only 15. That's why infant formula tastes so bland to parents, okay? But babies who don't have taste buds for sugar and salt, to them it's just fine. But you can see high fructose corn syrup is sweeter than sugar, but we use so much more than regular sugar. Now, where did it come from? Well, it was developed in Japan in 1966. After the war, the Japanese were in pretty bad economic shape. Two scientists found a way to use corn to make a sweetener. We began to use it in 1975. It's 20% sweeter than sugar, but we use more rather than less. Currently, the average person consumes about 63 pounds of high fructose corn syrup per person per year, okay? And we don't even know where it's coming from. We don't even realize we're eating it. Now, I'm going to skip this slide in the interest of time. Now, a study in the American Journal of Clinical Nutrition found that from 1970 to 1990, the consumption of high fructose corn syrup increased 1,000%, and it now represents more than 40% of caloric sweeteners added to foods and beverages. I challenge anybody to go into a regular supermarket and find 20 items other than meats and vegetables that do not have high fructose corn syrup in it, including mustard. It's everywhere. Now, what does it do to us? Well, glucose can be metabolized by any cell in the body. Fructose is only metabolized in the liver and is converted into free fatty acids much faster than glucose. This causes an increase in free fatty acids in the blood, which in high levels increases the risk for the metabolic syndrome. Again, hypercholesterolemia, hypertension, diabetes. Fructose is 7 times more likely than glucose to form advanced glycogen end products. Those are things that when you fry, for example, a McDonald's hash browns, that brown color you see, that's the glycogen end products that comes from the fructose. It does not suppress ghrelin. Ghrelin is a hormone that's produced by the fat cells that essentially tells us we've had enough to eat. Fructose does not suppress that, so ghrelin has a free rein to run. So the more fructose we eat, the higher our ghrelin levels are and tells us to eat more. It does not stimulate insulin or leptin. We'll talk about leptin in a minute, which is another hormone that helps us regulate our diet. Hepatic fructose metabolism, again, is different than glucose, and chronic fructose exposure promotes, again, the metabolic syndrome. Now, why do we use it so much? Well, number one, back in the 80s and 90s, the federal government said we need to take fat out of foods. Well, when we take fat out of foods, what does that do? It decreases the taste of the food. So the food manufacturers started adding high fructose corn syrup to increase the taste. So keep in mind, low fat does not mean low calorie. Again, I talked about the fact that it's a browning agent when we talked about the hash browns. And it also increases shelf life to allow us to freeze foods. Now, why is that important? Because what we have to do in order to ship food all around the world frozen is we have to take the fiber out of the food, and that allows it to be frozen. However, if you take the fiber out, again, you lose taste. So we add high fructose corn syrup to help us increase the shelf life. Again, it's a hardening agent, and it's also found in just about everything we eat. Okay. Now let's talk a little bit about fiber. I mentioned fiber. Fiber is probably the most important natural food that we have, but we just don't take advantage of it. Why is it important? Well, it reduces the rate of intestinal carbohydrate absorption. It reduces insulin response and lowers the risk of diabetes. It increases the speed of transit of intestinal contents to the ileum and it induces satiety. In other words, it helps us to feel full so we don't have to eat as much. And it inhibits the absorption of some of the free fatty acids to the colon, which also suppresses insulin. One of the reasons that fiber may have an impact on body weight is its ability to slow the movement of food through the intestines, reducing insulin response. And this increase in time that food stays in the intestines is shown to reduce hunger feelings and overall food intake. It's also shown to decrease the number of calories that we actually absorb from the ingested food. And one study found that more than 1,700 overweight and obese men and women, those with the highest fiber intake, had the greatest weight loss over 24 months. Fiber is king. Now let's talk a little bit about Coca-Cola. Is it a conspiracy, fact, or fiction? Now, I'm addicted to Coca-Cola. I'll drink a Coke no matter, if you put it in front of me, no matter how much I try, I'm going to drink it. And I think one of the problems with Coke, again, is, and the other soft drinks, is that because it has so much high fructose corn syrup, that we have a tendency to overindulge in it. Now, Coke was invented back in 1915. But by 1955, they had the 10-ounce Coke. The original Coke was only 8 ounces. But if you drank one 10-ounce Coke every day for 1 year, you would gain 13 pounds in a year. By 1960, we had the 12-ounce Coke. If you drank one 12-ounce Coke, you gain 16 pounds a year if you drank one every day. And keep in mind, there are about 12 teaspoons of sugar in one 12-ounce can of Coke. By 1992, we had the 20-ounce, and that would, if you drank one 20-ounce every day for a year, you gain 26 pounds. And by 1995, you had the 2-liter. And now, of course, we have the super big gulps and so forth and so on. It's gotten so bad, there's one fast food place in Texas where you can go in there and get a 44-ounce Coke or soft drink, a big-sized candy bar, and a bag of Doritos for $1. And we can do that because high fructose corn syrup is so inexpensive they can put it in everything. It's not that we've just now been using this. I found this ad on the web, and it talks about, for a better start in life, start cola earlier. We've been trying to get our families trained to drink sodas ever since the early 50s. Not to be outdone, Pepsi came up with this ad for 7-Up, and it says, why we have the youngest customers in the business. And you see how in that ad, it looks like the baby is drinking a bottle, a formula bottle. So it makes you think, well, it's perfectly wonderful. The baby's happy, and so forth and so on. So this has been going on for a long time. Now, why Coca-Cola conspiracy? Well, Coke contains 3 main ingredients, sugar, salt, and caffeine. Why? Well, Coke contains about 55 milligrams of salt. What does salt do? It makes us thirsty. It contains 45 grams of sugar, and it contains caffeine, which is a mild stimulant and diuretic. So the salt makes us thirsty, the caffeine makes us pee, and the sugar hides the taste of the salt and caffeine. If you remember, a couple years ago, there was this new Coke that came out where they increased the amount of salt and caffeine in the Coke, but nobody liked it, so they went back to the old formula. But they know what they're doing. They're trying to get us to eat it. Now, how can we help our kids? Well, this is one problem, sitting on the couch not doing anything. Well, we've been trying to help people lose weight for a long time. I found this ad on the web, and this is back in the early 20s, and it says fat vanished by using sanitized tapeworms. Okay? And I guarantee you, there are a lot of people who went out and bought a jar of sanitized tapeworms if somebody told them it'll help them lose weight. So that's important to realize that. Now, first thing I do is we have to educate our students, our kids, because they have no idea how to eat properly. And the first thing I do is I kind of go over the food pyramid, and I don't make it like a lecture, but this is the old food pyramid, and this is the new one. The only difference is they added the exercise man running up the steps to emphasize the importance of not only eating properly, but also exercising. Okay? Now, I take a few minutes to go over carbohydrates, fats, and proteins with the kids. I talk about fiber, but I don't spend a lot of time during the first meeting because I don't want to overwhelm them with information. But we do talk about that. Now, for those kids who are really motivated, who are obese, and I'm concerned about them developing type 2 diabetes and other comorbidities, I will talk to them about the glycemic index and glycemic load. And I briefly want to discuss this because this is important for kids, especially those who are, like I say, who are diabetic. Now, what does this mean? Well, if you look at the light, the red means foods that you shouldn't eat, the yellow means foods that you should eat sparingly, and the green means foods that are good. Now, let's compare a bagel to a slice of watermelon. Now, if you look at the glycemic index of the bagel, it has a glycemic index of 72. And if you look up at the scale, greater than 70, that means that that is a bad food. Look at the glycemic load. It has a glycemic load of 26. Again, you look at the scale, greater than 20, that's a bad food. So it's telling you not to eat a bagel. But look at the watermelon. It has a glycemic index equal to the bagel, 72. So it's telling you the watermelon is a bad food to eat. But look at the glycemic load, only 7, which is less than 10, so it tells you this is a good food to eat. Seems confusing. Well, let me explain the difference. A bagel is a complex carbohydrate, so if you eat a regular bagel, it's going to take your body longer to digest that carbohydrate. Your insulin level is going to rise, and it's going to be maintained for a lot longer over time to digest that complex carbohydrate. But the watermelon has a glycemic load of 7 because the sugar in the watermelon is glucose. The insulin rises but goes down relatively quickly because it can metabolize the glucose faster. So the insulin level doesn't stay as high as long. So if you're eating high-calorie foods, high-fat foods, high-carbohydrate foods for a long period of time, for years, eventually your insulin is going to remain high, and that's going to lead you to have a higher risk for type 2 diabetes and diabetes. That's the difference. So I know what you're saying because I thought the same thing. Well, how would I let my child know what glycemic foods to eat? Well, you can buy little paperback books that have foods in there that they can look at. Keep in mind, most of us eat the same thing over and over again. We don't deviate too often. And generally, if they have these books, and again, I only use this in patients who are really, really high risk for diabetes and other complications. Now, the CDC recommended 10 things that we should do for our kids to help them lose weight. And I used to go over all 10 things, but I kind of realized that that's not necessary because if you look at the things in red, you can see what the CDC recommends. Physical activity, physical activity, physical activity, physical activity, and so forth and so on. And let's look at the last 3. Physical activity, okay? So I think they could have done that with one slide, but the point is we have to get our kids to exercise. We all know why it's important. But does exercise burn calories? No, it does not. A lot of people think if I run around the track for an hour, that I'm going to burn a lot of calories. Well, first of all, most of us don't run around the track for an hour, okay? But exercise really doesn't burn calories. What it does, it improves skeletal muscle insulin sensitivity, it reduces stress, and it detoxifies fructose and improves hepatic insulin sensitivity. So I still encourage kids to exercise, but I don't lie to them and have them think that if they exercise, they're going to lose weight, because oftentimes that doesn't happen, and then they get frustrated. Again, these are some things we can do to help our kids exercise. Now, what is leptin? Briefly, leptin is a hormone that is produced in our fat cells and is stored in our fat cells and tells the hypothalamus to stop eating because we are full. A lot of us have a leptin gauge that is not reading well. So even though we just ate a meal, 10 minutes later we want more food because our leptin in our subconscious brain is not working and we think we need to eat more. And that's a big problem in a lot of our kids. And what we try to do is teach them to wait 20, 30 minutes before they eat anything else. Now, many obese people appear to be resistant to the effects of leptin and don't recognize the feeling of satiety causing us to eat when our stomach is already full, hence the leptin diet. Does the leptin diet work? Yes, if you follow it, but basically it's no different than the Atkins diet, the Japanese diet, or any other diet you're doing. Now, what about teenagers? Well, I don't like to use the word diet, but I don't discourage weight loss programs that teenagers think will work. Why? Because they will try anything, okay? I advise portion control along with exercise. I try to at least limit, if not eliminate, sodas and fruit juices. That's very difficult. A lot of kids now, I try to tell them, well, at least try drinking the Coke Zeros. At least that'll eliminate some of the sugar. But because they are so addicted to the sodas and fruit drinks, that's really hard to do. And I try to teach them about high fat and sugar foods to avoid when possible. But the most important thing I do is I tell them, before we do anything, you need to write down everything you eat for a week and bring it back to me. If they do that, even if it's on a piece of terrible looking paper or a napkin or anything, that lets me know that they are motivated enough where I think they really want to try to lose the weight. And then I go over what they bring back, and then we discuss how much they're eating, and also, if necessary, we'll refer them to a nutritionist because we're fortunate enough to have a nutritionist at our site. I explain why diets work short-term but have long-term consequences. And we do this over a period of time. We don't do this all in one visit. We talk about high-fat diets. We talk about diet supplements because they all want pills. We talk about the importance of fruits and fiber and vegetables. And I don't really talk about soy milk because they don't like soy milk. But I do talk a lot about fiber, and I give them examples of what kind of fiber foods they can eat. Okay. We talk about lifestyle interventions, get all sugary liquids, only water and milk, very hard to do. We tell them to eat carbohydrates with fiber. I tell them to wait 20 minutes for second portions. And this is also hard, but I tell them to buy your TV computer screen time minute for minute with physical activity. If you exercise for 10 minutes, you get to go watch TV for 10 minutes. If you exercise for 30 minutes, you get 30 minutes of TV or computer time. It's hard to do, but if parents are committed, then you'd be amazed at how much improvement you can see in their eating habits. I think we need to stop now. It's been an hour, and I'm going to see if you have any questions or comments or statements. If you have any information you'd like to share with me, I'd be happy to listen to it. Or if you have any questions about anything that I've talked about, I'd be happy to try to answer those questions.
At this time, if you would like to ask a question, please press star 1 on your telephone keypad. Again, for any questions, please press star 1.
Feel free to ask anything, and even if you don't have a question, if you have a comment that you'd like to make about something that I talked about, feel free to give your opinion, and because I like to learn from you as well.
Once again, for any questions or comment, please press star 1 on your telephone keypad. And you do have a question or comment from Levon Counts.
Hello. I was just wondering, you made a comment about Coke Zero and some of those other products. What about like Diet Coke and Diet Pepsi, those kinds of things?
I get that question quite a bit, and to be honest with you, if I had my choice, I'd rather them not drink any sodas at all, including Diet or Zeros. However, I've learned with experience, if you take something away from a patient and you don't give them an alternative, you're not going to get a positive response. My wife has become addicted to Coke Zeros, but she doesn't drink Cokes anymore, so I guess there's a trade-off there. So you have to start with something, but again, if they go to a diet beverage or a Coke Zero, I'm all for it because, again, there's so much high fructose corn syrup in your sodas and soft drinks that even if they are on a diet or on a lifestyle change and are trying really hard, if they drink 1 or 2 Cokes during the week, they can ruin everything they've done for the whole week. So it's a very good question, and again, I can only say if you take something away, you have to give them something in return.
Thank you.
Thank you.
Once again, for any questions or comment, please press star 1. Your next question or comment comes from Kelly Gray.
Hi, I was curious, is there any correlation of the data you were presenting on the increase in childhood obesity rates? Have they ever looked to see if there's any correlation in the increase in ADHD diagnoses also?
Again, that's another question that I get quite a bit. And the answer to your question is definitely yes. I have quite a few kids who are on ADHD medication. Some of them I start myself, but a lot of times I get referrals from other providers. And there is a concern that children who are on ADHD medication will gain weight. I've been fortunate in my patients where the majority I've had the opposite problem. They don't eat and they lose weight, and parents are more concerned about that. But there's definitely data about that. And now if the child is seen by a psychiatrist or a mental health provider, often they send them back to me for lab work because they want to monitor liver, everything, because they're so concerned about things like that. But I can honestly say in my natural practice every day, I have not seen a significant problem with weight gain with the ADHD medications, but that is a concern. And I think it's important that you let parents know that that may be a concern, so they're not surprised if the child does start to gain weight.
Thank you.
Thank you for the question.
And at this time, we have no further questions.
Well, thank you, Dr. Abbott, and thanks to all the NHSC webinar participants. We'd like to ask you to please take a moment to fill out the on-screen evaluation. Your opinion will help us further develop these webinars. Thanks again for your participation, and please take a moment to fill out this evaluation.